So we've had four, I think, really interesting and well thought out presentations this afternoon. We've got about 6 or 7, well, we've actually got more than that, 7 or 8 minutes for some questions now. And I've got some questions we've been taking off the Twitter feed. If you've got any questions from the floor, please raise your hand and Hard will take a mic down and we'll get some questions there. So if you do have a question, do please put your hand up. But I'm going to kick off with a question to Sarah first of all. I think, like a lot of healthcare systems in the NHS, we've got a lot of restraints around resource. And I just wonder what your thoughts are around, in psychology, around being able to provide that support and how we are constrained and how we can get around that resource constraint.
I think most of the changes that we were advocating was more about changing in team behaviour and ultimately changing the culture. So one nurse, when I was doing this work, one of the nurses admitted to me that she had walked past patients in distress because she simply felt too uncomfortable to go over and help them with it, and she was really worried about what can of worms she might open if she did go and sit down with them. But actually, with very little training and some support, all staff should be able to go and talk to patients about what's happened to them, and actually that doesn't really cost very much at all. And so, yeah, lots of the changes are more in how staff behave towards patients than investing in expensive staff. Although, as we demonstrated with the health economic assessment, that by getting a proper clinical psychology-led service, you'll actually save money to the NHS and to social care.
Great. And on that, you're sort of working in psychiatry at the end, there was a lot of work kind of done around psychology services. Is there evidence out there now that kind of shows that psychology services will actually stop the patient deteriorating and actually having to go and see formal psychiatry treatment?
There's lots of evidence around with lots of different conditions, notably chronic obstructive pulmonary disease, heart disease, and diabetes, that if people are given good psychological care, then their use of physical health services actually reduces and saves resources that way.
Great. Thank you, Sarah. So do put your hand up if you have any questions. If I move on to Anita, it's a really difficult topic for clinical staff often to deal with.
Yeah.
Do you have any advice as far as resources that people in the audience or people here can go to get things that might help them to discuss this with patients?
Yeah, absolutely. I talked around the different areas of improvement activity that have been taking place, and in particular the work of the Dying Matters Coalition, which is essentially a coalition that's across the country under the auspices of the National Council for Palliative Care. The Dying Matters website has a huge range of great resources. The sorts of resources that can help you into that way of having that conversation, again in a non-threatening way, because part of our challenge is us as health professionals equally having, not having confidence to talk about death. So lots of great resources on the Dying Matters website, again to take us into that conversation, to share experiences. And then in terms of working with health professionals and implementing good practice in all aspects of the end-of-life care pathway, the end-of-life care programme website is still live at the moment. And the resources that are on that website will take you through each of those steps of the care pathway, and there are a huge range of resources, a lot of which you can access at the moment in hard copy if you contact the contact details on that website. Those resources will be made available in going forwards within the new landscape around NHS improving quality. But they're there, and very much encourage you not to reinvent the wheel, but to look at those resources. One in particular, which is called Planning for Your Future Care, and I think we've had about 350,000 of those copies across the country, and that equally was written with individuals about what's important for planning, but a very good way in for professionals that are perhaps don't understand around advanced care planning, around the legal status of advanced care planning, documentation, what it includes, what it doesn't include. So there's some great resources. The End-of-Life Care Intelligence Network, full of fabulous themed reports. Again, intelligence around the data to support improvement activities for end-of-life care. So, and that's all on my handout, which if you can access that, you can access the website details. So www.endoflifecareforadults.nhs.uk.
Great. And how important do you think it is for training, so actual sort of face-to-face training in this area?
Sorry, Ashley, could you repeat that?
For face-to-face training, do you think face-to-face training, we need to have more face-to-face training in this area about how to help patients approach this topic?
Yeah, absolutely. And again, we've done a lot of work on communication skills training. Again, right across the board, but both in terms of developing and supporting rollout of various models of communication skills training. So building on some of the advanced communication skills training that were developed within cancer services. Again, there is no one model recommended across the country, but we have models rolling out, such as the Sage and Time model of communication skills training. We've got blended learning approaches whereby we're accessing e-learning resources. Again, we've got a whole suite of e-learning resources in all components of end-of-life care delivery, which is free to access in England for all health and social care professionals. So many of our organisations are taking a blended learning approach, so face-to-face contact, but some short interventions in terms of training and support. Again, we're doing a lot of training with GPs, with nurses, with social workers, and models of training and train the trainers that are rolling out across the country. And a lot of that is available on the website around where to access that information. But yeah, you're absolutely right, and so the Dying Matters Coalition are about to take forward their Awareness Week. So across the country there'll be a huge range of activities, which is getting out there into the supermarkets, but the kind of buses that going round, but actually just anywhere where there are members of the public to start initiating those conversations. So the coalition's doing fabulous work out there. And then our work around supporting professionals is, again, very much focused resources that are accessible.
Great, thank you. So Cathy, that was an intervention that seemed to have a really big impact on staff and patients in your organisation. One thing that we always struggle with is introducing screening tools and checklists with members of staff. How did the staff in your organisation react when you did that? Any advice for other people who might want to do something similar?
Yeah, we told them not to do it unless they were going to make a plan. I said to them, there's no point writing it down if you're just looking at the numbers. I'd rather you didn't bother at all. It's about the plan. And if you put the plan and you do it, it will protect you. Because I think we had to think about what was going to, what's the advantage of doing that. So there's a real advantage to us if people are recognising who the people at risk of malnutrition are. So that's what I wanted doing. But there are people who are going to be at risk of malnutrition that you can't fix. So people are going to continue to not eat well. They may continue to refuse food. Their requirements may remain high. Now, if that person then goes on to develop a pressure ulcer, particularly pressure ulcers in care homes, when people go back and do the root cause analysis, if nutrition has been highlighted as a reason, then the care homes get very, very anxious, as do the nurses. But if we can say, look, you made a plan, you did everything you could, then we can support you in that. So that's the way that we got them to do it. It's not about a checklist, it's not about screening. It's about knowing your service user and documenting what you know, and that's how we got them to do it.
Great.
And I don't let people not do what I say. We just kept going back and telling them the same thing over and over until they changed.
Fantastic. Nikki, so you talked about the hot phone service that you had for members of staff who had got questions, which sounds like a great idea because it's often a topic that people struggle to deal with, and it's great to have somebody they can call. How did you let staff know about it, and how did they find out about it? Was it something you went round and spoke to them about, or?
The number was included in the front page of the new formulary, so every member of staff had a copy of the formulary, and they had access to a mobile phone number, and that mobile phone number was paged through to a separate clinician every day.
And what sort of questions did you get, and how did the staff react to? Was it something they found helpful?
Can you believe we were so hyped up about taking away silver dressings from them and taking away iodine and the potential backlash about my patient's going to be in an awful state as a consequence? We did not have one phone call.
Wow. I think it's a reassuring thing to have, though. I think as a member of staff, you want to know there's somebody there that you can call and get advice from.
Now that might just because we're fantastically accessible anyway.
Probably, yes, absolutely. We've got last chance for any dying questions from the floor. If you've got a question, raise your hand now, Otherwise, I'm going to assume that we're all satisfied. I want to thank you. I want to ask you again to thank our 4 speakers this afternoon. If we can give them a round of applause. And just a reminder that our final keynote from Don Berwick is taking place at 3:45 down in the main auditorium, so we look forward to seeing you then. Thank you very much for joining us.